So, Dr. Irgau, why do patients drop at the last minute? What happens? So if you can just explain those to us, maybe we can be able to reach out to some others who are at that point so they can understand what's happening with them, and then hopefully we can reach out to more people.
Sure. It is a very important question, okay, Kemal, because to begin with, the number of people who are seeking bariatric surgery for the treatment of morbid obesity is actually a minority, right, compared to the people who actually need bariatric surgery. If you look at the prevalence of morbid obesity in our society, it has been increasing, right? It is one of those diseases that have become more prevalent every time we look at the data, year after year, decade after decade, right? And yet, currently, particularly for obesity that has really gone extreme, the best treatment we have is bariatric surgery. And it's also a time in which we have made bariatric surgery really a very, very safe endeavor, right? With the quality programs that we have put in place, and also with the evolution of the surgery itself that has gone from being a surgical procedure that required a big incision for which patients had to be admitted in hospital for several days. Now it's a procedure that is done with very small incisions, and very often, like in our program, it's an outpatient procedure. So you've got the right treatment, you've got a worsening disease, and yet the amount of patients who seek the procedure is very small. And then even after that, once the patients go through the consultation, as you correctly said, not everybody completes the program. Now, having said that, your program, as you know, Kemal, would be the one that should complain the list, because you've got a completion rate which is one of the highest in the country. We were reviewing this data not too long ago with our surgeons, and a completion rate that is close to 75% is unheard in many places. It's usually you see about 50% of the people who go into the program completing, and in the vast majority of programs. Nevertheless, it's important for us to ask these questions because we do want people to get help. Now, the first thing that we have to obviously clarify is that this is a decision that patients have to make for themselves ultimately. What we do is we provide the right information, we provide the guidance, we provide the recommendation, but ultimately it's up to the patients as to whether they want to complete the program or not. And of course, that is a given. The question for us is that, you know, they've gone through the program. It's not that they have resolved the problem, right? The problem is still there, and yet they have not completed it. So what are the barriers? What are the problems? Well, in part, as we've said many times, you and I, there is this huge stigma about seeking treatment when you have morbid obesity. It's not like other diseases, right? You don't feel any type of embarrassment in saying you're going to see the doctor because you have diabetes. You're going to see the doctor because you've got high blood pressure. You're going to see the doctor because you've got cancer, right? On the contrary, people will cheer you up for doing that, right? But when it comes to morbid obesity, somehow will people look at you and say, why were they not able to take care of it themselves? And this stems from the fact that our society still hasn't come to terms fully with the fact that obesity is actually a disease, right? They look at it as a self-inflicted problem that should be solved by the problem in their by the patient in their closet, right? And far from the truth, right? You and I have encountered patients who are so successful in life in many areas, whether it's education, whether it's work. They've set out to accomplish something and they've done it. And yet, when it comes to obesity, they are defeated. They cannot do it. And they cannot do it not because they don't have enough willpower or finances or trainers or guidance. It's because this disease is extremely difficult to tackle. That's why we're resorting to changing the anatomy of the digestive tract in order to combat it effectively. So the stigma associated with morbid obesity still is playing a part. And we see it in our patients as well. How long does it take for a patient to decide to come for a consultation? Well, usually, on average, it takes about 2 years. It doesn't take people 2 years to go to their doctor once they find out that they have diabetes, right? And yet for morbid obesity, that's how long it takes for most people. No, that is one part. The other part, obviously, is probably a lot of the obstacles that are placed, particularly from insurance companies, so that people don't really have a straightforward path towards bariatric surgery. Yes, there are preparations that are very necessary, that we recommend: education, right? Clearances, all those things, but they could be done in a much more efficient way if there were not too many obstacles placed by some insurance companies as well. So all this really, in my view, conspire to decrease the number of people who ultimately end up having surgery after they see bariatric surgery. Having said that, our program really should be extremely proud for what we do, which is particularly the case conferences and the associated processes that we have put in place help our patients, guide our patients to the extent that we have increased the completion rate to the levels that we have currently.
Absolutely. So I think let's actually talk about the insurance barriers, right? So in the state of Delaware, I think we are lucky that our Medicaid programs are extremely efficient to a point that they are the frontier of these types of coverages, and we don't have any issues with Medicaid. So just like any other insurance, any commercial insurance, Medicaid and managed care organizations, they are covering this, and there is no cost to the patient. So that's a huge plus.
Mm-hmm.
There are many of the big insurance companies, they don't have a coverage issue, except that there are some employer self-funded plans under the insurances that they may be, but we don't see that problem anymore. So then I would probably just take the insurance issue, like not necessarily for covering or not covering, but at least making it standard that they all cover. But then if we talk about like what's morbid obesity, is it like the 35 or is it 40 or is it like 30 to 35? So that's a different issue. But in terms of the coverage, I think we are good. In terms of this is actually tying that into the financial issues, there is really no financial impact on the patients. So this is, again, unless they may have a big, the deductible, that may be the case, but this is costing them on the long run a lot more anyway, being unhealthy. And, we were talking about in our diabetes session for the prevention, and when it's too late, and it's too costly. Mm-hmm. Too late is too costly. Like this is where we are today. So that's why that can not be an issue. I think the one that, as you mentioned, the lack of social support, the social stigma, and the one that is the fear and anxiety. I think that probably has a lot to do with some of our patients, because I see someone getting ready and just they're done. They're all like, and it's like 3 to 5, 6 months process, and how many different visits? Like just someone who's sometimes lazy to take care of his own health problems. Me, like it took 2 years to get one blood work done, and this patient did 18 different types of equivalent to the blood work, 18 different visits to the specialist, to the radiology, to the home sleep, like, all those things, and then yet at the end they are like, I'm not going to be able to go through. I guess this fear and anxiety is something that we probably need to look at. Is there any way that we can actually address that issue, or is it just like too personal that there's nothing we can do about it?
Well, I mean, clearly it's all about the proportions, right? I mean, there is always going to be a fraction of people that will be so anxious about the surgery itself that, they, even at the very end, they will, reschedule. I mean, I always talk about this episode way back when we started bariatric surgery. There was a patient who walked off the operating table. she just did. She did come back at a number of years later and have the surgery just because the problem was not solved. But this type of reluctance is just part of, it's natural, right? And some people will be reluctant. The question, obviously, that we're having here is that the number of people who are actually not going through the program is just substantial, given the enormity of the disease that they are facing, and also the fact that this is the most efficient treatment that we have currently, right? So I think educating our patients with sessions like this, for instance, people sometimes don't understand how much a program like this will go in terms of really educating people about these issues, Kemal. But it is precisely this type of the outreach that will have an impact eventually, right? Because it's all about education. It's all about understanding, right? It would have been the best situation would have been for the person not to have the problem to begin with. If they were not struggling with morbid obesity, there would be no issue. And if we could manufacture a reality where that was the case, then obviously we would have been a perfect solution. But the reality is not that. The reality is they are struggling with a disease that could potentially be lethal, that is wreaking havoc in their quality of life. And we are saying, look, of all solutions that we've looked at, this is the best solution. And we're providing it in a setup that is very safe, that is has high quality, but it is nevertheless a treatment that has a certain level of invasiveness, and that by itself does carry unknowns, does carry potential for complications. And those are issues that create real anxiety in people's minds. And of course, that it is understandable. But at the end of the day, as healthcare givers, Kemal, we obviously cannot dictate treatments. All we can do is obviously present our case to them and say, look, these are the risks and benefits of this option. These are the risks and benefits of this option. This is what the evidence shows about the benefits. This is what the evidence shows about long-term outcome of staying obese. So we recommend this treatment for you. And we don't say that in a nonchalant way, Kemal. We obviously have a setup whereby we go through their medical issue. We sit in consultation to understand in depth their individual problem. And of course, we involve many other specialists in this process as well. It's not a coincidence that we have a cardiologist, we have a primary care doctor, we have a bariatrician, a nutritionist, and a psychologist in this process. It's because we want to increase also the understanding in the patient's mind that this is a very serious issue that involves so many specialists that are going to support this decision that they are making, right? Now, obviously, we have set up a situation where we have decreased to a really the lowest possible level the potential for complications, right? I talk to my patients, obviously, about the risks of surgery, and I let them know, yes, life-threatening risks are not zero. They are a possibility, but we have placed measures that prevent these risks to a great level so that these risks are actually minimized to the lowest level possible, but it's not zero. And that is an understanding that they have. And when I present that, I also present the risks of staying obese. But very often, the risks of surgery are more immediate in their mind. The risks of obesity are more of a long-term issue, right? And the human mind cannot equate these two, and that's why many people have anxiety and fear about bariatric surgery, and then they don't go. But what we discover, as you perfectly know, Kemal, because you have the data in your hand, is that many patients who have dropped out this year will be coming back next year or will be coming the next day, right? So what they have done is they have prolonged their suffering with obesity. And the flip side of that is when you ask patients what they regret about surgery after they've lost the weight, after they become healthy, and they will tell you, my only regret is not having done this 5 years ago or 10 years ago or 15 years ago. Yes.
Time of the surgery and what they can and what they cannot bring and what you need. But in terms of expectation of who would perform the surgery is 99%, it's going to be the person who had the consult.
Yes, absolutely. That will be the surgeon that saw them in consultation will be performing the surgery, yeah.
Absolutely. Now I'm in the surgery center and I came there early in the morning. So what am I expecting for that day?
So obviously the surgery center not only will have called them ahead of time, but will have given them instructions as well. One of the important instructions, for instance, is to have nothing to eat or drink after midnight, the night before the surgery. But also the surgery center will ask them to take some medications, right? The medications that they may be on. If they're taking high blood pressure medications, for instance, we'll encourage them to take this medication with a sip of water. But as part of our preparation to have minimum discomfort from the surgery, we actually proactively ask our patients to take some type of pain medication even before they come to our center, right? That primes them to have less discomfort as they wake up from surgery. For instance, they will ask them to take 1,000 milligrams of Tylenol at home before they come to the center with a sip of water. And once they've come to the center and they've registered and they've come to the pre-op area, we will give them additional medication that are medications that will prepare them to have less discomfort after the surgery. So as you can see, there has been a complete shift in the way we deal with pain, right? Pain in the past, when I was trained, was something that patients complains about, and then you give them pain medication. So by the time you get to give them pain medication, the patient has been suffering from a lot of pain, essentially. But reducing the amount of pain that comes from surgery has been really a very, very important development in surgery, right? And surgeons have been very good now at paying attention to this very, very important fact. And surgery centers like ours have excelled in really adapting this, because there would be no way of really performing outpatient surgery if you were not able to control the discomfort that patients have after surgery, right? But how do we control the pain? Well, not only by giving pain medication when you feel the pain, but proactively preparing the body to have less pain. And we have medications that enable us to do that. And those medications are given even before the surgery is performed. Okay. There are also other things that we have to do. Again, this is all about prevention. It's about preparation. And one of the things we want to prevent, Kemal, is blood clots. Blood clots can happen with any type of surgery, but our patients, because they are suffering from obesity, they're actually at higher risk for blood clots as well. And so it is very important for us to focus on prevention of this. And there are medications that we give before surgery to do that, to reduce the risk of blood clots. And one of those medications,
part of our preparation process being
absolutely.
So good, because we want to make sure that we are able to identify these problems ahead of time.
Yes.
So part of the blood work that we do, and the reason that we have cardiology in many cases, this is helping us to eliminate these problems, because we don't want to have this issue at the surgery or right after the surgery. As you said, that our patients are high risk because of the morbid obesity. Now, in the surgery center, while we are there, the pre-op is about, I believe it's about 90 minutes, if I'm not mistaken. And then the surgery can be about like 60 to 90 minutes based on.
Absolutely. I would say it's anywhere between an hour and an hour and a half, sometimes an hour and 15 minutes, but no longer than that. And that applies to all procedures, whether it's gastric sleeve or gastric bypass. The actual surgery, really, probably on average, the gastric sleeve is about an hour actually in our center.
And as soon as the patient is in the recovery, we call it PACU unit. Then you mentioned the medications, the pain medications, and one of the things that we adopted, and I believe it's not very common in other facilities.
Well, no, it's being adopted now more and more, but we've been doing this for a number of years now in our center, where we have this, what is called enhanced recovery from anesthesia, which means that we want our patients to be able to be up and about very soon after the anesthesia wears off. And one of the things you have to be able to do that for that is you have to reduce the level of discomfort. You have to reduce other side effects of anesthesia, like nausea, for instance, right? And we do this, again, proactively. Well, one of the ways in which we reduce discomfort after the surgery, Kemal, is by strategically placing numbing medicine in the abdomen when the patient is already asleep, so that when they wake up, they don't feel the discomfort from the incisions. And as I told you many times, you know, early in my career, one of the dreadful things for me was to see patients waking up from anesthesia with a big frown on their forehead, suggesting that they're really uncomfortable, right? And we used to say, well, that's part of surgery. Well, actually, by doing this specific intervention with the numbing medicine, actually, you can eliminate that discomfort from the incision. So now when patients wake up from anesthesia, I see them waking up smiling, essentially, because of that. We're able to control that discomfort. And then similarly, because we are not utilizing strong pain medications like the narcotic, the opioids, for instance, we're able to reduce the side effects of opioids. You know, one of the side effects of narcotic pain medications, Kemal, is nausea and vomiting. Well, by eliminating those medications, you eliminate the the risk of nausea and vomiting as well. So patients will really be able to recover quickly from anesthesia, which means they will be able to be up and walking very early. And that's one of the goals of our recovery area for the nurses is they have, benchmarks. After a certain period of time, they have to get the patient up and walking. And when you're at the surgery center, very often you will see patients walking around. These are patients who've had surgery an hour and a half or 2 hours before, and they are already walking around. And that's tremendous because not only you are able to decrease complications by having the patient walking early, right? Like blood clots, pneumonia, and others. But in my view, when you're able to get patients to walk, Kemal, you actually transform the thinking of the brain itself. It doesn't think in terms of a sick person, right? Like if you're in bed and lying horizontally all day long, it's very easy to assume the role of the sick person who needs to be taken care of, who cannot do anything, right? But if you're up and about and vertical, you're assuming more of a person who's recovering, who is not sick anymore. And that's the kind of mindset that we want our patients to have, because that will be almost like a roller coaster, because they feel better. So therefore they will be walking. And if they're walking, they will recover faster. So it's almost like a cycle of positive. Right? Yeah, absolutely. That goes ahead. And this is reflected also in how long our patients take pain medication after surgery. Very often they will tell you, well, I took it for a day, maybe 2 days, and now we're off after that. And we're talking about major surgery, right, Kemal? But this is what you have to be able to prepare patients for, to provide really safe and high quality bariatric surgery nowadays.
But if you remember, this is one thing that I learned from you early on when this is kind of like my next thing to remind our patients, you don't stay there overnight. So the average discharge from the PACU, from the recovery is, average range is about 6 to 8 hours.
Yeah.
So we had in the last 12 months, a little over 400 cases, only 2 patients had to stay, and they have some special issues, not clinical, so we had to keep them. So they will go home. The idea is the whole mentality of like, am I sick or am I recovering? And where do I get recovered the fastest? Because there was this misperception of, well, if I'm in the hospital, I'm safer. Well, that's not correct. Hospitals are not safe from that point if you don't have to be there.
Absolutely. Yes, I mean, of course, as we always say, there are certain patients who definitely need to have their surgery done in a hospital setting because they require specific treatments for other conditions that they may have. This may be severe heart disease, kidney disease, lung disease, where we will need them to stay in hospital longer. We will need the input of specialists and so forth. But for the vast majority of our patients having elective bariatric surgery, it's an outpatient procedure for that purpose. Of course, as you mentioned, if patients need to stay overnight, we have the capability of offering that, but the vast majority of patients don't require that. So in terms of what patients are going to be expecting, of course, even though this is outpatient surgery, they will be with us for about 6 to 8 hours after their surgery. So as far as the patient is concerned, it's an all-day affair, essentially, from the time in which they arrive to the surgery center, they're in the recovery area, and then about 6 to 8 hours afterwards.
So the key is like early mobilization.
Yes.
Is preparing, and I think the hydration. Do we want to actually kind of address the hydration issue? Like, if anything that I do prior to surgery, in terms of better hydration, is there a way to do that, or is it something that's going to hit and miss?
Sure. So first of all, education is important. It's important for our patients to understand that hydration is very important. Now, why do we emphasize on that? Well, because after the surgery, because their stomach is very small and it also tends to be stiff very early, they cannot drink a lot of water at once, right? So the strategy that they have to adopt is to drink small amounts but frequently. Right. So the way I explain this to patients, Kemal, is I tell them there are two ways of filling a bucket with water, right? You can put the bucket under the tap water, turn the tap on and the water will just fill the bucket, right? But another way of doing it would be to keep the bucket there and let the water drip from the tap, right? If you let it drip continuously, eventually that bucket will fill up, right? And that is important for our patients to understand that there are ways for doing that, but they have to proactively take little sips continuously. So if they are not talking, if they are not asleep, they are sipping water, which means they must have some water with them at all times. Now, what is another reason for why patients require more fluid after the surgery? Well, not only their stomach is small, as I said, but they're also not eating the way they were eating before, right? And when you and I are eating normally right now, Kemal, a lot of the food that we eat has a lot of water already. In fact, most foods that we consume will have 60, 75, even 80% water in them. So when we're eating, we're actually hydrating ourselves. Now, when you've cut your eating to a much smaller percentage now, you've also cut your hydration to a much smaller percentage than before, right? Your body still needs that level of hydration that you needed before, which means that to make up for that, you have to develop these strategies, okay? What do we do as a center and as surgeons to help our patients to achieve that? Well, we help them by avoiding things like nausea and vomiting, for instance, and that's again part of the preparation, right? We avoid medications that cause nausea. Many of our patients will tell us, oh, I'm in this phase group, of bariatric surgery patients from all over the place, and all patients are complaining about nausea and vomiting. And then I keep telling them I've had my surgery at the American Surgery Center and I don't have any nausea and vomiting. Is there something wrong with me? And I keep telling our patients, no, there's nothing wrong with you. It's just the way we design the preparation for our surgery minimizes nausea. It's also important for us to inform of our patients of many other aspects that may change in their life after bariatric surgery. And to that extent, probably it's helpful if we talk about early after surgery, midway, and then long term. What are the things that probably are not discussed as frequently? So first of all, very early after surgery, within the first, few hours to the first few days after surgery, one of the concerns many patients will have is, how much pain will I have? Will there be a lot of discomfort? And the important thing to mention here, Kemal, as you know, is as part of our bariatric center at the American Surgery Center, we have really implemented a protocol, a setup really that allows really minimum discomfort after surgery by preparing our patients even before the surgery with certain medications that will minimize really the pain itself after surgery. And as you have seen it yourself, 2 hours or an hour and a half after surgery, you see our patients walking the hallways of the surgery center, and you have to be reasonably comfortable to be able to do that. So we're not saying there is no pain, but the pain should be mild, or if it's moderate, it should be manageable with mild pain medications. Essentially, that's the expectation for most people. And the vast majority of people will not need pain medications beyond the first 2-3 days after the surgery. And certainly no major narcotic pain medications are used after surgery. And the surgery, as we always say, is done laparoscopically. So the actual cuts on the skin, the incisions, are actually very small incisions that tend to heal very quickly and with minimal discomfort for the vast majority of patients.
Now,
Another thing that comes up is,
I'm so sorry.
yeah, go
Going
ahead.
back to your patient earlier, this patient lost 40 pounds, 40% of her initial weight.
Yeah.
So can we actually talk about this a little bit more? And
Absolutely.
I have
Absolutely.
a small technical issue here, and if you see me doing things, it's because I'm trying to fix something here.
You're the presenter and the technician.
All right. Sorry, go ahead.
Yeah, absolutely. So essentially, it is extraordinary what, bariatric surgery can do in terms of really confronting this major problem, which is morbid obesity. And as we've said many times, and that's the reason we say that, is currently really the most effective treatment we have for morbid obesity is bariatric surgery. And, I was asking the patient, hey, do you have any challenges, any problems? She said, well, I have one regret. And I said, what's that? And she said, oh, I wish I had done this 10 years ago. She's in her late 30s now, and she wished she'd had done this in her 20s rather than struggle all these years with morbid obesity. And she has been, up and down with the weight many times, but she was very happy with that.
Well, in terms of what to expect, Dr. Irgau, if we can actually perhaps talk about the follow-up care a little bit, because that's the key for success. And although our patients are, in some cases, they may be a little bit overwhelmed with so many appointments they have, but now when you lose 40% of your total body weight, that's a big responsibility. It becomes a big responsibility to maintain and know how to deal with this new life. So can you actually talk about the follow-up care a little bit and see how?
Absolutely. So the follow-up is critical, both in the short term and in the long term. Definitely in the short term, it's very important because we want to make sure our patients are recovering well from the surgery. In the early days and early weeks after surgery, we are focused to make sure that there are no major complications with the surgery. And if patients are not progressing the way they are, we will certainly want to know about that. And one of the best ways to ensure that is to have a scheduled follow-up process, which we have in our practice. As you know, as soon as the patients are discharged, the next day, the surgery center calls the patients to find out how they're doing. And then at 2 weeks, patients have an appointment with our office. And then again at 1 month. And then after that, at the 3 months mark, and then every 3 months after that as well. And this support is very important. As I said earlier on, we want to make sure that recovery is happening without any hindrance. And we want a patient to tell us if they're having any unusual symptoms that may indicate that they may be having a complication. Fortunately, complications are extremely rare, but this is the best way really to be able to address them, is that patients are that they follow appropriately, and that the follow-up is done in a timely fashion as well. And then in the long term, as you said, it's not a question of only losing the weight, but it's also maintaining that weight loss as well. As we talk very often with our patients, bariatric surgery is a powerful tool, and a tool nevertheless. The actual biology that drives that relentless journey of our body to really gain weight all the time is not really taken away with bariatric surgery. So patients have always have to be on their guard really about maintaining a healthy eating habit as well as regular physical activity for them to be able to stay healthy in the long term. And in that process, the follow-up is important because that creates accountability, but also any issues that may arise that could potentially sabotage this can be addressed if the follow-up is done in a timely fashion as well. So follow-up is very important, and part of the process that we have set up in our center, as you know, because you set it up yourself, is to have a database that allows for us to really trace our patients and continuously communicate with them if the follow-up is not done in an appropriate fashion.
Absolutely. And Dr. Irgau, most of our patients, they do have different comorbidities as like different illnesses, chronic illnesses. They may have diabetes, they may have hypertension, In terms of medication that patients are taking, what type of changes are we expecting them after this significant weight loss they have?
Absolutely. So again, great points. I was having office hours today. One of the patients had a very high A1C before surgery, and the A1C is normalized now. Another patient was telling me that soon after surgery, actually they were feeling dizzy, especially as they got up. And that is really a sign that their blood pressure was going down. And my first question was, what blood pressure medications are you taking? And the patient was continuing to take their blood pressure medication, but as their weight loss occurred, their blood pressure was normalizing. So if they were continuing to take blood pressure medication, now the normal blood pressure was going low, and that's how. So one of the things we instruct patients is to make sure they follow up with their primary care doctor very early after bariatric surgery, so appropriate adjustments can be made to their medication. So if they were diabetic, now they may require less medication or no medication at all. Similarly, if they had high blood pressure and they were on a number of medications to try to control that blood pressure, which was very high before surgery, now that they're losing weight and the morbid obesity is being addressed properly, blood pressure will lower down. And so they may need either less medication or no medication at all. So those are very, very important issues right after surgery that have to be addressed. And one of the reasons why we need to have this close follow-up schedule as well, because we can address these things that happen differently from individual to individual.
So nutrition is another part of the next life, I guess, the new life. So what should we be careful for nutrition? What is it that we have to do so that we don't have multivitamin issues or malnutrition issues? And do we have to follow up with a nutritionist, or do you advise that to the patients?
Absolutely. So that's a very important aspect of the changes after surgery, right? First of all, there is actually a definite progression in terms of the diet right after surgery. Our patients are instructed to be on a liquid diet for the first 2 weeks after surgery. And then after that, they go on to what we call a pureed diet until they are about 4 weeks after surgery. And then after the 4 weeks mark, they can start introducing chewable food. So the main point here is the consistency of the food. The first 2 weeks, they're just going to be on a liquid diet, which would mean just drinkable things, nothing else, right? And then after that, they can introduce more substantive food, but again, they cannot have anything that requires chewing. So one of the best way to explain to patients is to tell them that they have to pretend as if they have no teeth, right? So anything that's going to go into their mouths will have to be something they don't require to chew. It can be swallowed as it is, just like baby food consistency, right? And there is a very important reason for doing that, and that is because the surgery itself has led to certain wounds on the stomach or the intestine, depending on the type of surgery, that require healing. And if the patients introduce chewable food early, that can actually create injuries to the healing organs that could lead to complications. So it's very important for patients to really stick to this schedule. Now, another thing that is important that it's not talked about very often is that this surgery itself, actually, at least in the first few months after surgery, introduces some changes in the way patients actually appreciate taste and smell, to the extent that certain things that they loved before surgery, they may not care for now, or certain things that they didn't like before surgery may be much more palatable now. So those changes are transient. They are very much expected. So patients should not be surprised by that. It happens very often. You will actually find patients not being able to go to the kitchen because the smell of food really turns them off, just because their sense of smell is so much more heightened. That really doesn't last very long, but that can create some nausea and sometimes even some apprehension. But that is temporary and it will pass. That is something that surprises patients if they were not prepared to know about that. And then as they introduce chewable food, as you said, they have to see a nutritionist as part of the follow-up for them to be reminded about the type of healthy food that they need to keep on eating in the long term, or they need to keep introducing as they are eating chewable food. Another thing that is important for patients to understand, Kemal, is now depending on the type of surgery they've had. For instance, if we take the sleeve gastrectomy, which is by far the most common surgery that we do right now, whereby we make the stomach a lot smaller. So the stomach that was large and compliant and accommodating, now it's more tubular. It looks like a banana, but also it's much tighter. It doesn't give in very easily, which means that as they are swallowing, there may be pressure that builds up in that stomach that backs into the food pipe. So when they're swallowing now, they may be more aware of this function, right? Before surgery, as you're swallowing, you're not aware of that passage of the food down your food pipe. But after surgery, you may be aware, and particularly if you're eating more than what you're supposed to eat, you may feel it as discomfort. And that is something that patients need to be aware and expect. Obviously, there is a fair amount of trial and error as they learn about this, as they start to become conscious about not going beyond that extra bite that may cause discomfort as they're eating, and they, acclimatize themselves gradually to eating just enough so that they don't have discomfort when they're